I told you that in like previous class when we were studying biochemistry, I told you we will be studying the synthesis of acetylcholine and we will be studying the adrenergic drugs, adrenergic agonists. But then I kind of it reminded me that we have only studied these muscarinic antagonists, and we have not studied the nicotinic antagonists. Okay, so in your first aid book they have not given the nicotinic antagonists, they have only given the muscarinic ones. So we have studied the muscarinic ones. Today we will be studying the nicotinic antagonist. If you remember from yesterday, when I was teaching you, I made a classification. Okay, I made a classification. So this is not the classification, but I kind of made a classification. So wait for a second. Mm, so this is the classification. Okay, and let me share the screen with you people. So you see, this was the classification which we studied yesterday, and we are done with these anti-muscarinic agents, or I can say muscarinic antagonist. But these ganglionic blockers are still remaining, which are not given in your first aid. Okay, so today we will be studying nicotine, okay, which is a depolarizing ganglionic blocker. Then we will be studying hexamethonium, mecalamine, and there are few others also. Okay, and then we have this NMJ blockers, in which the most important one is succinylcholine and tubercularine. Okay, now in order to understand this, I will draw a kind of a chart. People, once again I'm telling you, this is not given in your first aid book, so it is better if you make your own notes here. Okay, and I will give you these this Microsoft Word file. I will give you this file, but it is better if you make your notes. Okay, so now uh, let's say this is a ganglionic blocker. Okay, we use the symbol NN for ganglionic blocker, and we use the symbol NM for neuromuscular junction blocker. Okay, so this is an NN antagonist. Okay, okay, or I can say ganglionic blockers. Okay, slash, or I can say ganglionic blockers. I will divide it into two. I will divide it into two. One is called depolarizers. Okay, and the other one are called non-depolarizers. Okay, I'm not writing the complete spelling here, just you know, depolarizers and non-depolarizers. So nicotine is a depolarizer. Okay, you can make your flow chart and you can write number one nicotine here. Okay, and in non-depolarizers you have this hexamethonium, you have this mecamylamine, then there are other drugs like trimethophan, etc. So we have like five non-depolarizer drugs and one depolarizer drug, which is nicotine. Okay, so you should know this is the classification of ganglionic blockers further. At first we divided the cholinergic agonist, the cholinergic sorry the cholinergic agonist into two, antagonist into two: muscarinic antagonist and nicotinic antagonist. But the nicotinic antagonists are further divided into ganglionic blockers and neuromuscular blockers. And in ganglionic blockers, the NN antagonist, we have depolarizers and non-depolarizers. Okay, so today we will be studying the ganglionic blockers mainly, and if we will have time, we will touch the neuromuscular junction blockers too. Okay, and then I will take you to the acetylcholine synthesis. So first complete the cholinergic chapter. Okay, people, so let's get back, because we do not have that in first aid. So I have made these notes, and I will explain you from them, but they are not into detail. I have just written the main key features, and I will explain you in this lecture. So you have to make your notes while listening to me. Okay. So what does the word depolarizing means? First of all, first things first, when you are classifying it into two, the depolarizing and the non-depolarizing, you should know why we call it depolarizing. Okay, so here is your presynaptic neuron, okay, and here is your postsynaptic neuron, okay. With the influx of current and the release of acetylcholine in the synaptic cleft, the receptors present here, when acetylcholine binds to these receptors, there is an influx of sodium inside. Okay, this influx of sodium inside depolarizes this membrane. It depolarizes this membrane. We just read in today's neurophysiology lecture 2 that it is called a receptor potential. Okay, so it depolarizes this membrane, and sodium ions rush into the membrane. Okay, so this is what we call depolarizing. But there are drugs which are non-depolarizing as well. Okay, so in those cases, these drugs are not directly getting attached to these receptors. Okay, and they are not causing an influx of sodium ion, but they are dealing with the enzyme acetylcholine esterase, and they are activating this enzyme more so that it may function on acetylcholine. Okay, so that is the basic difference between a depolarizing agent and a non-depolarizing agent. One more thing you need to remember, that a depolarizing agent, okay, for example nicotine, okay, or for example if I'm talking about the NMJ blockers, we have a drug called succinylcholine. Okay, succinylcholine. So for example this drug, these drugs work as acetylcholine. Their function is just as similar to acetylcholine. Okay, but they are resistant to this buddy, acetylcholine esterase. They are resistant to it. Okay, let's say for example, let me make it more simple for you. Let's say for example, this is nicotine. Okay, this is nicotine, this is not acetylcholine. Okay, now this acetylcholine esterase know that this drug which you're using, which you have intake, works in a similar fashion to acetylcholine. And what this do, it hydrolyzes this acetylcholine into acetate and choline. Remember, I taught you the synthesis of acetylcholine. In that, I told you this step, that ACH breaks acetylcholine, hydrolyzes acetylcholine into acetate and choline. So the same, it will try to hydrolyze this nicotine as well. Okay, it will try and hydrolyze this nicotine as well. but the nicotine is resistant to this. Nicotine has a self-protective barrier, okay? All the depolarizing agents, be it succinylcholine, they all have this self-protective barrier and they are resistant to this acetylcholine esterase. Therefore, at first the action when nicotine when nicotine or succinylcholine is binded to this, at first, if I'm talking about the neuromuscular junction over here, okay, and if we have succinylcholine, okay, if we have succinylcholine here, and this membrane is an NMJ, and then succinylcholine will bind to its receptor. At first, it will produce twitching of muscles. The muscles will twitch, and we call it fasciculation. So you can write it that the depolarizing agents works as acetylcholine, but they are resistant to this acetylcholine esterase. That is why at first, when they bind to these receptors, they perform because of the inward current, because of this influx of sodium and an inward current, because of the depolarizing activity, the muscles twitch. There is twitching of muscles, which we call fasciculations. Okay, FASCI, fasciculations. Okay, LANTION. Okay, so fasciculation we call it. But after some time, when it remains binded to this receptor for a longer period of time, there is a point when the 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 current is reaching high up, and let's say, for example, this is a muscle, this is a conduction going on in a muscle neuron, okay, in a somatic nerve fiber, and it reaches to plus 55, and when it reaches to plus 55, the depolarization will end and repolarization will begin. So there is a point where the depolarization has to end, no matter what, like even if the drug is still binded to the receptor, the depolarization will finish as it reaches to the end voltage. That is its limit to it. Okay, so then what happens? The twitching is gone and you will see paralysis. We call it flaccid paralysis. Okay, the muscles will become flaccid, they will become loose, and they will paralyze. Okay, so flaccid paralysis. Okay, and the reason to it is that the receptors that are present here, the acetylcholine receptors to which this succinylcholine is binded, these receptors become desensitized. Okay, they become desensitized. So do you people understand how a depolarizing agent works? This is the mechanism of action of the depolarizing agents. Okay, so let me quickly repeat it once again. What is happening? All the depolarizing agents like nicotine or like succinylcholine or like hexamethonium, there are other drugs also. Okay, they work same as acetylcholine, they work same as ACH neurotransmitter. Okay, and these drugs are resistant to this enzyme acetylcholine esterase that hydrolyze acetylcholine. Okay, so acetylcholine esterase cannot work on them. So at first, when they bind to the receptor and there is an inward current going on and depolarization takes place, the muscle will twitch and fasciculate. Okay, there is a small portion of the muscle where you will have hyperactivity or hypercontraction, so it will twitch and fasciculate. But after some time, these receptors to which these drugs are binded, they become desensitized and you will see flaccid paralysis. So in the side effects, in the side effect profile, you will see paralysis, you will see atony. Okay, same here also, and same in NMJ drugs also. So let's move to the side effect profile now. So you guys understand this mechanism? People who are listening to me, please write in chat if you understand this mechanism so that we can go to the side effect. Okay, Okay, so Aisha, do you understand it? It is very important to understand the mechanism of action of drug, and these drugs are not given in your first aid. So either you have to go to your textbook to study, or you can study it along with me. Okay, so nicotine is very important. And now I'm clearing this all picture. Okay, so like you can also listen it in your recording section. Okay, Aisha, very good. Let's move on. So our topic of today is nicotine, and we will study it on two levels. Okay, now you see what I've written. I have only written the important points, and I will explain the mechanisms to you. Okay, I've not like made like everything in writing, so you have to stay focused. So nicotine is not used as a drug except for smoking cessation. We use nicotine. Nicotine is present in our cigarettes. Okay, but we use this nicotine for smoking cessation purposes also. So the mechanism is same to you. At first, when you will prescribe nicotine to the patient, it will increase the effects as a cigarette do. It will do the same things as cigarette, but because it will remain binded to that receptor for a long period of time, that receptor will become desensitized, and then you will have the opposite to what a cigarette do, and it will help you leaving the cigarette. So it also helps in the smoking cessation, like stopping the smoking. Okay, so now we have to go with the side effects, higher doses. Okay, so the first one we have is respiratory paralysis. How nicotine is causing respiratory paralysis? Now, diaphragm is a muscle. Diaphragm is a skeletal muscle. Okay, so you should have a neuromuscular junction present over there, but that's not the case. Nicotine goes high up in your brain. Okay, nicotine has a tendency to cross the blood-brain barrier. Okay, and it can go to your CNS and can affect at that level. That is why when you drink cigarette, you are like in peace, in euphoric state. You are like flying, and you're in relaxation, and all your stress is gone. So you're in that condition. So it affects your CNS. So nicotine does not work on muscles. On muscles, all the skeletal muscles of your body has this NM receptors, the neuromuscular junctions. But this nicotine has, it works on NN. Okay, so make this thing clear. It has no function on the diaphragm directly. It it goes to the brain, it crosses the blood-brain barrier, and it affects on the respiratory centers high up in the brain. Okay, in your what I can say, in your hypothalamus. Okay, and also at the level of your brain stem. So if you people have not gone through yet, you all have that recording of my neurophysiology lecture, in which I discussed these respiratory centers in the hypothalamus and brainstem. So there I also discussed about the respiratory center in the hypothalamus and brain. Okay, so we have two anterior and posterior respiratory centers in hypothalamus, and then we also have in brain as well. Sorry, in brainstem as well. Okay, at the level of medulla oblongata. So you can go and see the physiology portion over there. So what I'm trying to tell you is here is this respiratory paralysis is not done on the level of diaphragm. It is done at the level of your brain. Okay. Then you have this GI atony. Then you have this what I'm doing. Then you have this GI atony. Okay, like gastrointestinal atony. Now atony, it is like A means no. Your muscle has no tone, no contraction, no relaxation, no tone of muscle. Okay, So what will happen when you have no tone in your smooth muscles of your gut? You will not be having your food digested, your food will not go further, and ultimately it will result in constipation. So you can correlate the effects of agonist and antagonist now. If you remember, we have that mnemonic which was dumbbells, DUMBBELS. Okay, this was the mnemonic dumbbells, and D means diarrhea. D means diarrhea. So when cholinergic agonists are causing diarrhea, the antagonists are causing constipation. So now you get that sense of how it is working. Okay, then also bladder atony. Okay, so this is your urinary bladder, this is your detrusor muscle, and these are your sphincters. Okay, when your bladder will not contract, it will ultimately relax. And when your bladder will relax, it will not feel pressure. When it will not feel pressure, that stimulus of pressure will not go into your central nervous system, the response will not come, and you will not urinate. So the result will be urinary retention. That is, you will not be able to pass the urine. So the result will be urinary retention. Okay. But there is another very important concept that you should be well aware of, that nicotine has not its effect only on these mechanisms, but it also has its effect on the vessels. Now, what your agonists were doing on your vessels? The activity of agonists on your blood vessels were dilating them. They were dilating the endothelial lining, which is of smooth muscle, made up of smooth muscle. Okay, so the smooth muscles of your blood vessels were dilating, so they were increasing the diameter of your blood vessel, so that more and more blood can like flow easily. But now what they are doing in this case is they are causing the vasoconstrictive effects. Okay, they are constricting your blood vessel. So at first, in the start, you will see hypertension because of vasoconstriction, but because the duration of action and all these things are very long, and they are the depolarizing agents, they will desensitize the receptor to which they are binded. And after some time, the hypertension will be converted into hypotension. And that hypotension will be really severe, okay, and it can lead to it can lead to even cardiogenic shock. Okay, but very few people undergo this. Okay, but you should remember, severe hypotension is a side effect because of its vasoconstrictive effects. That is why you see the contraindication over here is angina. Okay, in angina patients, what happened, that the myocardium of your heart, this is your myocardium of the heart. Okay, let's say for example, the myocardium of the heart have blood supply. Those arteries of your myocardium, when they have blockage, let's say plaque, the blood do not flow in a linear manner. The flow of blood is linear, okay? But because of this plaque, the blood has this turbulence. And after some time, the blood undergoes stasis. So, you know, that thing can cause low perfusion to your muscle, to your heart muscle, the myocardium. Okay, when that particular part of your muscle got low blood or low perfusion, okay, the contracting ability of this myocardium becomes poor. And when there is this systole phase, the systole means contraction. Okay, when there is the systole phase and the ventricles, both the right and the left ventricles have to contract, that contraction is not powerful and that is poor. Okay, so then the blood goes to your other parts of your body less, and then the patient feels this angina. This is the angina is basically a pain. It is not myocardial infarction. Okay, the part of that heart muscle is not infarcted. It just has low perfusion and it is causing a pain that we call angina pectoris. Okay, so you see, it is because now nicotine is caused. There is this patient who is a heart patient who has plaques in his blood vessel, and you're giving that patient nicotine. Let's say, for example, to stop smoking, and that patient will have this vasoconstrictive effects on the blood vessels, and that will increase the predisposition and increase this angina to vulnerability. Okay, so this is a contraindication and very important contraindication. Then hypertensive patients. In long term, it is causing severe hypotension, but severe hypotension is also harmful. Okay, the patients who are hypertensive, if we will give this drug so earlier, it will cause excessive hypertension that can cause problems like stroke. So you are not allowed to give nicotine to these patients. So these are the contraindications. So apart from these activities, they also have some vasoconstrictive effects, severe vasoconstrictive effects. Okay. So I'm rubbing this all. Okay. I hope you understand. If not, you can ask again. Okay. No problem, I will repeat. So if we're talking about side effect, low doses, because it goes high up in the brain, it crosses the blood-brain barrier and it reaches your brain. So the patient goes in on low doses, it will function the same as the cigarette do. Okay, so at first the effects will be positive, but at later stages when the receptors will desensitize, the effects will become negative. Okay, so in low doses you will see euphoria, pleasure, arousal, relaxation, enhanced cognitive functions. All are same to cigarette smoking. Okay, all are same to cigarette smoking. So in order to stop smoking, in order to cause smoking cessation, we give nicotine in higher doses, because the person is already getting these things. Okay, but the problem with these people who drink lots of cigarette is they crave that pleasure. They crave that pleasure that nicotine or tobacco gives to them. So what you're doing is you are giving that person pleasure for a very little amount of time, and then he got into that pleasure, and after that he don't know what is going on inside his body, and his receptors are desensitizing. So gradually with time he will not feel that urge to smoke. So this is the whole mechanism. Okay, but also the person will have some serious side effects, which are these, and one of them is respiratory paralysis, which is a hallmark. So you have to see the doses. So nicotine in smoking cessation comes in patches. Okay, you apply these nicotine patches in the arm of the patient, and they are slowly absorbed. It is an intradermal drug. Okay, then so we are done with the depolarizing drugs. The next is non-depolarizing. Okay, but there are some more things that I want to put a light on them with nicotine is, if you see this, the MCQs can be very tricky sometimes. So if I talk about a very tricky MCQ, let's say they have not mentioned respiratory paralysis and they have not mentioned hypotension. Okay, hypo, they have not mentioned hypotension, they have not mentioned respiratory paralysis, and they have not mentioned hypertension, but instead they use the word sympathetic and parasympathetic. And they're like now asking you that how this nicotine is doing sympathetic and parasympathetic effects. No drug is there that do sympathetic and parasympathetic at the same time. But we have this drug which is causing hypo and which is causing hypo and it is causing hyper. Okay, so you see, the hyper action is sympathetic and the hypotension action is parasympathetic. Getting my point? So this is very important. Respiratory paralysis and hypotension, they both are parasympathetic effects, but hypertension is a sympathetic effect. So at first, in the start, we will see sympathetic effects, but later after the receptor will desensitize, we will see parasympathetic effects. So keep these concepts really clear. Okay. Then I want to tell you something about the dosages that are very important regarding nicotine, because nicotine is the most important drug in the antagonist section. Okay, so when the patients will go into deep pleasure and arousal and all these things, and when they will see these nicotine side effects. So smoking can also cause it not only causes this relaxation or euphoria, but it leads a person to to a deadly state that you have to rush that patient to the hospital and give him oxygen or intubate, like if taken in big doses, more doses. So if the patient is habitual of taking nicotine via cigarettes, if he's taking like 1 to 2 mg, now these are clinical points which you will be seeing when you'll be working in a hospital. So they're not given in your textbook, but like maybe it should be given in your Kadzung or in your Lippincott. I'm not sure about it. But 1 to 2 mg of nicotine to like 6 mg of nicotine is okay. Every day, some people take 1 cigarette, some people take 10 cigarettes, some people do take 40. But not in a day, but there are people. But those ones who are like chain smokers, if their dosage of nicotine exceeds 60 mg, okay, 60 mg, that is lethal. What you understand the difference between a lethal dose and a toxic dose? This is a lethal dose. The patient may die, and you need to take him to the ICU and intubate it like as an emergency. So this 60 mg is a lethal dose. Okay, and how this nicotine is cleared, the clearance of nicotine is also important for your clinical setup. It is cleared by lungs, okay, by the liver, okay, and by the urine. So the metabolism goes here, okay, and because it's absorbed, or you're taking it more in the form of cigarettes, so it is cleared via lungs, it will be absorbed in the blood, and then ultimately from the urine. So you have to remember these 3 clearance names for the nicotine. So I guess this is more than enough knowledge for insulin. And any other point, if I remember, we don't give nicotine to pregnant women also. So remember this also, okay? You will never prescribe nicotine in pregnancy. It is contraindicated, okay, in any cases. So the next topic will be non-depolarizing drugs, and we have like 5 minutes 56 seconds timer left. So this recording will disconnect in between, and you have to join it again. I want to complete the non-depolarizing drug today, and we will study all these drugs together, and they are very easy. This is very easy. Non-depolarizing is really easy. because it do not have that mechanism like nicotine. Okay, it does not have that mechanism like nicotine. Okay, pehle sympathetic effect, then parasympathetic effect, not like that. Okay, so it's I have, you see, I have like left these portions empty so that I may write with you. When I'll be explaining, I will be writing with you. So this is like just this little part, and it's very easy. It's just opposite to agonist. Okay, so if I am beginning the lecture, but if we disconnect, students, you can join again from the same link that is posted in your WhatsApp. Okay, because we are reaching 40 minutes now. So now these are the non-depolarizing drugs. Okay, they do not reach that threshold and then they desensitize that the receptors. This is not their process. Okay, so the drugs are hexamethonium, mecamylamine, pentamethonium, pempidine, and trimethophan. Hexamethonium is still used in clinical setups. Okay, and in somewhere you will see trimethophan, but the other ones are not too much used. Okay, so their actions, now the actions are important. So these all will be the actions. Okay, so their actions are opposite to agonist. So for agonist, the best is you can remember the mnemonic dumbbells. Okay, dumbbells. So this was the action of this was the action of, this is E and L and S, sorry. So the actions were, these were cholinergic actions: diarrhea, increased urination, meiosis, that is constriction of pupil, bronchoconstriction, bradycardia, emesis, that means vomiting, lacrimation means more production of tears, and sweating. So these were the actions of cholinergic agonist drug, but we are studying antagonists. So all the functions make it opposite. So for diarrhea, it will become constipation. Okay. Now let's go one by one. Okay, if I'm talking about GI, what will happen? If I'm talking about GI includes mouth. Okay, we start the GI tract from mouth. So what you will see in mouth, if there was increased salivation, dumbbells, it has double S. Okay, one is for sweating, one is for salivation. When we had increased salivation in cholinergic, you will see decreased salivation in antagonists. Okay, so decreased salivation, your mouth will become dry if you will use these drugs. Okay, dryness of mouth. Then come to stomach. So now when we are at stomach, what will happen? There are two things that will happen. Okay, number one is the production of gastric acid, that is HCl. Okay, HCl production will decrease. When the HCl production will decrease, the emesis effect will not occur. So you see, when you were taking agonist drugs, you were having vomiting. But when you are taking these antagonist drugs, the HCl is not producing more. So the patient will not have that feeling of vomiting. Okay. Number one, no vomiting. Number two, HCl is released from your gastric parietal cells of the stomach. Okay, and it also helps in the digestion of food to maintain the pH. Okay, so what will happen here is your pH will go to the alkaline side. From the acidic, it will go to the alkaline side, and your food will not digest. So it is causing no digestion of food, like not no, but decreased digestion of food. Okay, so decreased digestion. So this is the third effect on the stomach. And then if I talk about the gut lining, for say example, if I'm talking about the small intestine, the duodenum, the jejunum, and the ileum, what is happening at these particular levels, that they will cause constipation. How constipation? Because the gut motility will decrease. Okay, the cholinergic agonist drugs were causing diarrhea. because of the increased gut motility. But the antagonists are causing constipation because of decreased gut motility. So these are the actions of these drugs on GI tract. In mouth, you will see dry mouth because of decreased salivation. In stomach, decreased HCl production will lead to no vomiting sensation and decreased digestion. And in the gut, decreased motility will cause constipation. So I think you're clear with the actions, okay?